can we bleed from? We can bleed from pelvic venous, first 90% about, from pelvic arterial injury about 10%, and remember the most interested are superior gluteal artery, the pudendal artery, the obturator artery. More common case of hemodynamic instability. As Professor Yotov told a few minutes ago, the hemodynamic instability of this patient is a very important note of the prognosis of this patient. Another search of bleeding is the bone surface of fracture, all the visual injuries, or more combination of all of these. And remember the extrapelvic injuries, because in major trauma, probably the pelvic or the abdominal trauma is the most important, but probably there are also other extrapelvic injuries. Two questions. Why patient with a fractured pelvis bleed to death? How much blood we can lose into our pelvis? Remember that the hemorrhage from pelvic fracture is essentially bleeding into a free space, potentially capable of accommodating the patient's entire blood volume without gaining the sufficient pressure-dependent tunnel rate. Remember, it means that quite all the blood, the volume blood of the patient can reach the pelvis without any other problem and without any pressure-dependent operation. Where does the blood go? The first unit, as we told now, in the pelvis, in the open space of the pelvis, but also in the retroperitoneal space. It is the retroperitoneal hematoma. This is a virtual space in connection with the pelvis, so the blood can reach also the upper part of the abdomen. The volume, as was always underlined, the volume in the pelvis can reach also over 4 liters. Sometimes it's not big in time. It means that you have to think about the bleeding and the region of the bleeding first in the first moment. Potentially is treatable if you recognize the origin and you are able to fix the hemodynamic condition of the patient with the images that you probably know better than me. The mechanism of the injuries you know very well. I will go fast. This is normal. This is an anterior-posterior compression. It's about 15 to 20%. This is lateral compression. This is the most common. This is a shear force, vertical I mean, or a combination of all these. What should I do if I suspect a pelvic fracture? Now I expect a question. How to understand or why I am to suspect there is bleeding, there is an important potential bleeding fracture. So, remember they could die from bleeding first. And the patient pelvis is very careful. Do not roll the patient. Use the orthopedic scope stretcher as Professor Yotov told a few minutes ago. Give generous anesthesia, blood, plasma, and fluid, but also practice permissive, because if the pressure is lower, the bleeding may be less. But it must be controlled, of course. Evaluate serial hematography to understand if the bleeding is continuing or is only linked to the trauma moment. So, how to assess the pelvis? Bringing the values may be interesting to put a good diagnosis in time, but please do not continue. Also, the direct territorial language may be interesting to make a perfect diagnosis of a building, but please do not continue to do it. And besides, the aspect of flags of stratum of the perianal area, major disruption, the length of the leg, the discrepancy, the standing abdomen, also the symptoms like tachycardia, hypotension, abdominal pain, pelvic pain, and others. What about the imaging? Of course, the X-ray plain film is the first, and you can do it in a few minutes, as Professor told a few minutes ago. The echofast is also very interesting because in a few minutes you can have an idea about the breathing, about the mass in the pelvic area and the abdominal area. The angio-CT, the CT or better the angio-CT, remember. This is a problem because you need more time, you need a complex structure to perform rapidly an angio-CT and the angiography with the embolization if you have important bleeding. A good X-ray investigation is always required. You can have very good images, but if you have a very good CT scan or CT at three-dimensional reconstruction, what about the vessels? Management of a pelvic trauma with the suspected bleeding. If you have this kind of suspect, please perform rapidly an angio-CT scan. And if you think the bleeding is not approachable by endovascular procedure, open the patient and fix the pelvis and open the patient to start the bleeding, or if possible, if you have the, enough good structure in your department, you have an angiography suite with a specialized person like the vascular radiology intervention and the vascular equipe do an angiography and defibrillation. Now I expect one question. Open the patient or do an endovascular procedure? The answer is very easy, because if the lesion is approachable and you have in your department the endovascular procedure, first perform endovascular procedure. Otherwise, you will open the patient. There was a patient there was a small fracture of the pelvis, but a terrible bleeding because of a gunshot. This is a patient with a bleeding. Look at this, the arteria is the obturatory artery is one of the most interested artery in pelvic fracture. This was an angiography, there was a catheterization, and now there is no bleeding. Probably you are looking for the spiral. We put a small spiral into the catheter, but unfortunately, in this, if you don't have a very strong magnification, it's not easy to see the spiral because with the subtraction technique of the angiography, sometimes to see the spiral is not so easy. So this is an interesting case of trauma, pelvic trauma. You see the great hematoma in the lateral surface of the pelvis, also here. And think about that, look for this small bleeding. It looks small, but it is not the entire bleeding. And in the angio imaging, you see only a small bleeding, but it is not absolutely small. There is we performed a catheterization and we put it in the spiral. You can see here the first part and after the bleeding finished. Another case of the bleeding of the obturatorial artery. The patient, as you see, is a bleeding in the internal part. The obturatorial artery, you know very well where it is. And there was a catheterization, and we put spiral and no more bleeding. Another case of superior arterial bleeding. The patient was had a trauma. I'm sure you believe me, the patient has a pelvic fracture, but I don't want to give you too much images. This is the bleeding, the catheterization, first image and final image. Another case is the bleeding of the obturatorial artery. You see here. Also here, this is the catheter, two orthographic images, and after the selective to the iliac artery, the internal iliac artery, to the obturatorial artery. This is, you probably ask why we continue to see the bleeding. It is not bleeding, this is the contrast medium is blocked in the hematoma. In conclusion, there is not any slight pelvic injury, maybe. Early intervention, minimal pelvis movement for the patient. Be suspicious of vascular injury. Remember, bleeding can lead the patient to death, and be prepared for vascular repair. Thank you for your attention.
And I think also this speech is very interesting, and younger surgeons can obtain useful information. I would like to ask you a question. Could you give us some practical information concerning how to deal polytrauma patients concerning his bleeding? So, I mean, it comes in our emergency room, we have a blood examination. How many times after the first examination is useful to perform a second one to evaluate the hemoglobin level and connect this information together with the pressure, the systolic pressure, and other information?
As was already said, this is a multidisciplinary problem, of course. Brain trauma is absolutely a very important problem. The orthopedic have to treat at first the patient, and they have, you have to think about the bleeding. In the case of hemodynamic instability of the patient, and the suspect of a real bleeding, our suggestion is to perform angio-CT. Now I expect a question. Angio-CT with the contrast medium or without? Because the real problem of an hospital is the radiologist asks you, may I perform contrast medium to the patient without any preliminary investigation, without know something about the renal patient, to know about the immunity problem of the patient. This is a big question. If you think the patient is losing his life, do it rapidly. There is also another possibility to perform a CT scan without contrast medium. Why? But the answer is very easy. If you see in the pelvis of the abdomen a great volume, what do you think it could be? Of course, blood. So, but the second question is, where is the bleeding? So in the second case, you have to perform a biography. So you have to do the doctor's reading the same. Any case, the most important thing is the orthopedist have to be suspicious first. And after, if you can perform angiosity, ask the vascular surgeons or the intervention radiologist and perform an embolization if the ulcer is possible.
And questions? No questions from the floor, so we can move to the speech of Dr. Mazzoni. He will talk about navigated total hip replacement.
Thanks once more for the invitation. This time the topic for me and many would be something which is quite hard to support. I want to give you an idea of if navigated arthroplasty. Well, to start with, of course, is what determines the most effective and safe positioning of an arthroplasty. All of us know that chapter 1, of course, should be, and I say should, be a good pre-op planning. But we may not have templates. We may not be able to use because of X-rays done on CDs or on screens or on films which you don't know how much are larger, whatever. At the end of the day, what happens, you will not be able to, very often today, to calculate pre-op exactly what you're going to do. But if you do, you will not be one of the most frequent to do it, because unfortunately, as far as everybody can tell, but not too loud, pre-op planning very often is not common. So what happens, we all go there and we do it because we know we are able to do it. But, as many of you know, I'm basically just a hand surgeon. So what happens is that my statistics is quite low. It's just the wee bit you need to be confident and justified in using that sort of operation. And moreover, there's something else which is very, very important for me. I live in a small city which name is Ascoli. It's 50,000 inhabitants. And if I have a favor, if I have an ancestral or result, for sure will not be exactly on the paper, but the day after, the day square. There's a lot to talk about, and so I can have favors. So, what will I want to control when I want to go to a safe position of my total hip? Of course, it's always the same story. You have to hear these things this morning more and more than once. I need to control leg length, the offset and the anterior version, the stability of my implant. Today, with modular implants, it seems to be fairly easy, of course, to dominate also the offset, that very often is the most difficult to control. And if you have normal stems, your brand you usually may have different offsets of the same stem. Otherwise, you go into modular, as I said, and that makes it apparently easier. And I say apparently because one of the first things you have to remember is that depending on which is your surgical approach, lateral or posterior, your broach will have a major or minor difficulty in entry into the channel. And it may happen very often that you will go with your stem in varus rather than in the correct position. So some brands give you different approaches depending on the surgical approach you have. This is more critical in the anterior, which I noted before. And as far as stability, you can control this with at the same way. What happens when you start reading today, you have these beautiful angles already set up on the support of the reamer, and you just have to control that, put them perpendicular in the correct position compared to a floor, and that is eye control. So it's not really what you can tell as a very fine refinite control. In both anteversion, inclination, and in both the most common surgical approaches. But what saves you very often after you did everything? And what? And you're very convinced you did a good thing, is that you feel there is a bit, it's quite okay, but there is a little bit of instability. But all the brands give you beautiful inserts, but on the other page, there's always the anti-dislocation bit. The type of anti-dislocation bit that saves you, gives you much more degrees of control. And the modular neck, of course, means the rest of the game. Because when you have such a choice, you just have to have the patience and the time to do the choice, which makes your hip very stable. But those who has seen starting with modular necks knows that modular necks are not really the most reliable hip implant as far as their structure. They have stress fractures on and many of the items which are on the market had to undergo revision of the work and that sort of thing. So it's normal for me to take a look at total hip navigation. Why? Because I commonly navigate. I navigate knees, of course. And since 2006, all my osteotomies, and moreover, all my total knee has been navigated. Why? Because I have been, in the past decade, working for more than a year as a consultant in one of the institutions in Europe which has the highest number of navigated knees and of navigated cases performed through a year. It's 350 total knees every year just in this institution, which makes all the scientific institution in which this man here, which is Protesi, which is the inventor of orthopedics, which is the first system of navigation, and Fred and his team do other 400. So at the end, I had the chance to work in a place where the use, where everything was so you think of navigation also for a hip. How do you do? Just an like these, you record your morphological data, and you start to read, and you have your tools which are able to transmit their position, and you can be aware and where you are exactly as far as depth of your reading, orientation, and inclination, diversion, and you go and you know what is the size you're going to go in. So this is what happens. You can use different different softwares. Every brand, of course, has its own software. This was Rayma. This is Striker. And what happens at the end, what is stressed is that you have a great accuracy. But do we really need this accuracy in positioning the cup? Of course, if we miss for 3 degrees a tibial component, it will not be as good income. But we are very lucky because the hip forgives our mistakes or not accuracy in a very wide way. We were considering with one of you that if you have 10 plus or minus degrees of antiversion, which will save you on 15 degrees you are supposed to do, well, it's a huge amount of possibility to, let's say, misalign your cap with no major effects. But a very interesting work we carried on while I was there was to try to see if there was a real difference in a team which is confident with navigation and to see if there was a real difference in the amount of the maximum diameter, the average of the maximum diameter of the femoral head we were removing and the diameter of the cup we were implanting in 2 groups. One was 40 total hip navigated, and the other one was 40 total hip navigated, not navigated. Well, what came out? That the average difference was 2.6 millimeters, which will not seem too much, but in sometimes can be a problem. So, at the end, this means that if you re-navigate it, you may realize, you may be able to achieve a significant saving in your boat size. This, another area, another topic in which navigation in that hospital had been used in hips is in the surfacing. And it seems, as even confirmed by the most recent literature, that probably is the best way to avoid failures of this particular type of implant. And here you see the different type of software once more that allow you to be perfect in putting it center the stem of the surface. So the big problem can be the learning curve, and as I told you, I was very lucky because I had a chance to work in an institution of this kind. In approaching to the hip, as soon as I got there, I started to work there. The first thing they did, they sent me to Berlin, where to make some cadaveric and solvent courses on knees and on hips. And so we were used to deal with that sort of. So, how does it, how do you perform it exactly? I have 5 minutes video. These are drums on which you hook the transmitters. And they're going on near the spine, the iliac spine. And you're mapping now this exact position. Draw say, and the third point you need is on the pelvis. Now, once you have these three, you have 3 points which will never change if you keep only one, because each transmitter has 4 balls that will always move in a direction which is strictly tied to the other 2 we map. So now, with one single trigger, we have exactly the position of our pelvis. Circular approach is the one there. This device finishes the greater canter. So this has the meaning on the femur side, on the femur mapping. Screw there, tighten, and you put support for the transmitter. And the transmitter. This is a passive transmitter. It's not the one you've seen in the scene. I'm talking to the young residents. You map the patella point. This gives you length and rough axis of the femur, and you map the ankle, both sides, to give an idea of exactly of what the position, the axis of the limb is. You remove the head of the femur, and you go and map exactly the acetabulum. You need at least 5 points. And the more large you have to make, the more uneven the cut is. So you check with a small trial, you turn it so to give to double check the hip center as it was normal before reaming. And here you go reaming, and your device, your reamer, has a transmitter. So while you're reaming, you know how far you are from the lower part of the cup, and you keep very still on the orientation, 45 and 15 of that inversion. And this is where you are when the image is stopped. But in the meantime, you have to measure out of your cup. This is the cup. Of course, we're talking about press fit, non-cemented. While you hit, you can still check the final implant. You navigate the final insertion. And once more, you double check that your implant is exactly with the center of rotation you are looking for. If all these are all green, the same sort of green, that's where you are. Now you go on the femur. This is a short stem, so the technique of reaming is a bit different than usual. As you can see, you press cancella stone, and here you go with your stems. So you have to try out there. Reduce and check. Check. The size of the stem is the one more correct for what you need. Now you put transmitter there. And this being a modular system, will quickly tell you exactly what sort of neck you need. The best, instead of fiddling around with that model. And here you see age choice 130, 135, 140. You see exactly if it's what is the best to make up your choice. In the meantime, you are double checking all antiversion, retroversion, and you remove it, clean, put, try it. The final. That's it. So why should I navigate an archery class? I have some personal reasons, probably, because what we know is what seems we have safe position on the cup, we have optimal stem position, but we can manage. We have seen that with traditional way of implanting. But for sure, we try to avoid. With this, we avoid outliners a lot. We have a very standard possibility, and so we avoid all these problems, which are a very common possibility of failure of the implant. But more than that, personally, I think that that is not the most important reason for which it can be useful in selective cases to implant with the help of navigation. Because, as we said, it's not terribly needed a perfect precision unless we have a very critical situation. I mean, it's just when I have to read because I have a very poor bone stuff. I mean, I can't read too much, so I have to be as precise as possible. And those three images give you an idea of where probably navigation can be more useful. And last question. Will I probably do in the future? Or is there something coming that can be more helpful than navigation regarding head arthroplasty? And today they're trying to talk about robotics in all fields of surgery, also in microsurgery, which is amazing. But the system is roughly like navigation because it's imageless. You acquire your data. The software, as you see, is very similar to the ones you have seen. But the point is, you don't control anymore. So it's not like before, I need to control. You don't control anymore. There's the arm of the robot that will go where you have decided it will go. And if your data have been given in a correct way, everything will be okay. But if your data, which is the most common problem that can happen in acquiring, getting prepared to navigation or robotics, is not have been done in the correct way, can happen. What happened at the demo? The only time I used a robot, the data weren't perfect, so the robot won on the pelvis and just broke it. Fortunately, it was so long because it was thin. That's it. Thank you.
Thank you, Dr. Mazzone, for your very interesting talks. And are there any questions from the audience, from the floor? No. Just a question for you. As you know, I spent some month of my life working with Dr. Genie in Strasbourg, who is a very, is a man who uses navigation to do knee and exactly. What I want to ask you is, I agree with all the things that you told us, but considering that this technique has to be done in an institution with a low volume of hip arthropathy, and considering both the learning curve and the economic aspect, do you suggest to use this technique only in big institutions, or we can imagine that in our practice we can choose to use navigation even if we work in a small institution, small hospital?
There's an option to solve the problem. When you're 50, stop everything home, go in a major institution where they're doing common that sort of surgery, and come back a year after, and you're ready for it. It's a joke. That's what happens when our techniques evolve constantly. So it's not possible for us to do everything we did when we were a registered, a resident. Once in a while I try to remember which type of surgery I performed the same way I used to do it when I was a resident. And I can't find a single operation which is done exactly the same way. It's 30 and more years maybe since then, but staying up to date is an essential part of our work, because otherwise we are not able to give good performance. How you acquire that? A bit of determination to do it.
I have to say that you as usual, you are very honest. You showed us one of your slides, and it was written that even if navigation allow you to achieve a better position of the implants, hip and sternum cap, however, we are not sure that this better positioning correlates, is associated with better clinical outcomes.
Well, this is a standard problem in hip surgery, in hip arthroplasty surgery. This is sure. One thing, the point of navigation is just that the thing which is absolutely undoubtable is that outliners are drastically, dramatically reduced. And of course, the biggest part of your pitfalls is in outliners, for sure, not on the normal basis.
Let's move forward to the last talk. It's
Hello?
images. Can you see the post-operative X-ray?
Yes, we can see it. I would like,
Okay.
please, I would like some information about the age of the patient, the range of motion before the operation, the range of motion now, and if, how much she gained. And if we can see bones for all right and left center of rotation.
This is the situation in Bulgaria. Unfortunately, this is what we get usually from our X-ray department. And we waited for more than 30 minutes to get this X-ray, so this is the only thing that we have post-operatively. I can switch in between the pre-operative and the post-operative so that you can feel the difference. This is the post-operative, and now you can see the pre-operative. You see that it was necrosis of the femoral head solution, and post-operatively, I think we managed to restore the original center of rotation. We managed to restore the offset And after the surgery, we saw that we equalized the leg length. So I think the purpose of the surgery was achieved. We restored the original center of rotation, and we also restored the offset. So the prosthesis was very stable. Professor Gaspari tested it. I don't know how much is the range of motion you tested it.
Okay.
We had about 20 degrees of extension, more than 90 degrees of flexion, and both intra and extra rotation were full.
So,
Yes? There is like discrepancy. Did you count the 2 centimeters?
yes, it was about vertical, and now we measured after we placed the lady on the bed, the legs were equal after surgery. So I think we have full range of motion. We equalized the legs, so I think the purposes of this surgery were achieved. So this is was my first time with the dual fit, but I think it is a good prosthesis. It was easy, applicable, and surgeon-friendly prosthesis. So I recommend this prosthesis to my colleagues from the auditorium.
Okay, thank you very much. Thank you. Bye.
Finally, it's my pleasure and a great honor to present you the last talk. It will be done by Professor Rosa, who will talk about pelvic surgery in chondrosarcoma.
As everybody knows, chondrosarcoma is the second most frequent bone tumor of primitive bone tumor, and in the hip bones, in the pelvic bones, chondrosarcoma is more frequent. Certainly, we have to keep in mind that we have different grades of aggressiveness of this tumor, and we have to keep in mind one thing. Chondrosarcoma is a tumor that can be cured only with surgery, because it is chemo-resistant and is radio-resistant. Well, as you can see in this image, you have a second degree chondrosarcoma, because histology shows you binucleated cells and different in sizes and different in size and with different aggressiveness, with different size of the nucleus. This is very important to distinguish the histologic aggressiveness of a chondrosarcoma. And chondrosarcoma certainly has all these peculiarities that I tried to summarize before, but you have to keep in mind that it is a tumor that we can cure without great aggressiveness, doesn't give metastasis, except in the third degree or in some peculiar histologic cases, when we have, for example, a dedifferentiated chondrosarcoma or a mesenchymal the surgery of this kind of tumor must be done in very close cooperation with the anatomopathologist, and without him we can do great mistakes. And this is a case, for example, differentiated chondrosarcoma, and you see on your left there is a chondroid tumor. On your right it is a tumor that differentiated into a fibrosarcoma. This is a high magnification of that image. On the left it is cartilage. On the right is an aggressive malignant fibrosarcoma. Histiocytic fibrosarcoma. As in this slide, we summarize and the frequency of the malignant bone tumors, and as you can see that in the pelvis, the chondrosarcoma is the most frequent tumor. The localization can be either in the ileum or in the acetatum or in the pubis. In Usagi work of 97, we see that the ileum is chondrosarcoma is more frequent than in pubis and ischium. And around the acetatum we find the highest percentage of this tumor. Prognosis, as I said, depends certainly from histology, from treatment, and from also the dimension of the tumor. And if you have to say something about surgery, we have to say that we must always remove the tumor with safe margins, so a wide resection is recommended. Except if you are in front of a grade 1 or a grade 2, in that case you can remove the tumor with a curettage, doing a curettage and using nitrogen because this adjuvant help in preventing relapse. Second problem referring to this tumor is the reconstruction. The reconstruction must be done in relation with the surgery you have employed. And certainly we have all the problems that you have when the tumor is located in the pelvic bone, and we have to think what will happen if we don't reconstruct the continuity of the skeleton, and the problems that we have with the recurrences. functional results at the end must be taken into consideration. The patient has to know what he will recover after the operation. This is our, it is my personal thesis. This is the inclusion criteria taking into consideration the absence of metastasis and diagnosis. I had the opportunity to see a Mafucci syndrome. You know that Mafucci syndrome is a congenital disease where multiple chondrosarcoma are associated with angiomas, and it is a very aggressive syndrome with a high percentage of metastatic metastasis to the lung. This was the patient. This was the patient. This is other cases of huge chondrosarcomas. We can see the first one on the left, huge chondrosarcoma of the anterior pelvic ramus of the ischium, and the preoperative evaluation must take into consideration certainly the standard X-rays, the bone scan. It is important to see if the lesion is solitary or there are multiple lesions in the skeleton. And then if you have before surgery, you have to do certainly a CT scan and angiography in some cases, because as this one, this chondrosarcoma that was located in the pubis that obliterated all the obturatorius canal. Certainly we have to do the stage, and we have to make our choice and what kind of operation has to be taken into consideration. Margins must be adequate, but for aggressive chondrosarcoma must be wide, and can be we can do intralesional resection, interlesional curettage or marginal resection when only when we have in front of a first degree, second degree chondrosarcoma. Local adjuvants in this case give great help because can allow us to preserve the continuity of bone, to do the marginal interlesional excision. Certainly, surgical technique resection techniques in the pelvis must be adapted to the location of the tumor, or if it is on the iliac crest, the surgery will be quite easy. If it is in the anterior arch of the pelvis, surgery it is quite not difficult, but if it is in near the acetarium, have to reconstruct the bone continuity using either prosthesis, custom-made prosthesis, or you have to use allograft. Prosthesis is a good solution, but we have an infection rate that is still very large. Certainly, in my experience, prosthesis doesn't give the same number of infection than allografts, but infection rate is still high. Complication of prosthesis is the implant breakage, the aseptic loosening, infection, as I said before, and very prosthetic fractures, neurological problems, and some relaxation of the location in the movement. If you see a case like this, you see this girl, she was 18 years old, 18 years old, and she had a hump on her left flank, and as you can see, it was due to an osteochondroma who was degenerating into a chondrosarcoma. In this case, surgery was quite easy. We could remove the osteochondrosarcoma that in just cutting the internal cortex of the ileum, and so also the shape of the ileum was preserved. You see that only the internal cortex of the ileum was taken out of the tumor, and we just dissected the iliac muscle from the internal cortex of the ileum. And the shape of the iliac crest was remained normal. This is another case. It is a first degree chondrosarcoma located at the bottom of the acetabulum. It was studied. You see the classifications inside the tumor. It is the sign of dark lesion. This is the ileum approach that we performed. Curettage and reconstruction in this case, curettage, liquid nitrogen, and reconstruction with bone taken from the breast and fixed with two screws. This is the X-ray after 7 years. This is another case of pelvic chondrosarcoma, a huge chondrosarcoma that interested all the all the rest was taken by the tumor. You can see this CT scan. In this case, after 12 hours of operation, we could not, we did not have the time to reconstruct the pelvis because the condition of the patient were not good. The patient spent 2 days in resuscitation, and then he recovered. And this is the view of the patient, picture of the patient 10 years after the operation. Certainly, he has a big leg discrepancy. He has, but he has his own leg and can walk with difficulties, as you can imagine. This is another case, type 2A chondrosarcoma around the acetabulum was the only location. It was in a woman of 35. We did resection and reconstruction with custom-made prosthesis of the pelvis. Specimen. This is the image. This is the functional result of this patient that the Plovdiv a normal life. Now we have 12 years of follow-up. This is another case. This is the reconstruction. This is another case, a huge, also chondrosarcoma of the pubic ramus with gradation. This is the anterior aspect of the thigh, the anteromedial aspect of the thigh. These are X-rays. Surgery is inguinal plural approach. This was the result after the war. This is another case. He had a bump on over the ischium. This was the X-rays and the arteriogram. The gross specimen, the resection. This patient, I operated him 15 years ago or more. It's more than 15 years ago. He's still okay, and he has surgery. Now we have surgery to insert the prosthesis because there was as you can see in this image, folks arthrosis. This is another case, a girl of 18 years old who had this aggressive chondrosarcoma over the anterior arch of the pelvis, inguinal plural approach. This was the removal. This was the immediate X-rays. I can say that the patient married and she had 2 children, but I think that the operation, in this case, the canal of Bartum, the canal was enlarged, so no problem really. another case, sarcoma in a multiple sclerosis disease. X-ray, also X-rays. So we had only 10% of recurrences, 5 years survival rate 100%, no metastasis. This is our functional outcomes. Then, conclusions. When resection is the best treatment for pelvic sarcoma, custom-made prosthesis employment is good choice for period tablet reconstruction in high malignant tumors. Without forgetting that when you do this kind of surgery, you must work in a place where you can find all these colleagues that will help you in making that diagnosis and help you for treatment. Thank you very much.
Thank you very much, Professor Rosa, for your wonderful speech. I would like to ask if there are any questions from the floor. Any comments?
Just a question. You have shown us Anouillet syndrome, chondromatosis multiplex.
Anouillet with angiomas, then it was demolished.
So
you must remember
how, which is something rare, but in a career it can happen that they bring you kid with this sort of problem. How do you survey lesions to beware and get to treat the lesion while or before it moves into chondrosarcoma?
Nowadays, when you see Protesi syndrome, you must ask the genetist to do a carrier, because now they found a peculiar gene, and so in this way you can do a better prognosis. But certainly you have to survey, but you must survey the patient one time a year and for all his life.
If there aren't any other questions, I would end this session. I think that we did good work. We are in time, even a few minutes before the scheduled time. I would like to thank you, Professor Popstefanov, who is the moderator of this session, and all the speakers for the excellent talks. So thank you very much.